Good morning, everyone. Today, I want to discuss about the new management protocol for mucormycosis, which is now popular as black fungus. This is of utmost importance in present situation of this COVID-19 pandemic, as this is a diagnosis we cannot afford to miss. Now, actually, the complete treatment and management strategy it should be a multidisciplinary approach. It should involve an ENT surgeon, an ophthalmologist, a neurosurgeon, neurologist, pulmonary medicine, or general physician. So, actually, this involves few responsibilities. That is, we should assess the time to time situations, and it should involve the guidelines for the prevention and treatment, and it should give also involve the public oriented messages for awareness. So, we'll go to the types and the symptoms of mucormycosis. This mucormycosis is an aggressive angioinvasive fungal infection. Basically, this is a infection. This infection is acquired by the inhalation of the environmental sporangiospore in an immunocompromised host, or it can directly enter during trauma and affect this host with severe metabolic conditions. Now, there are 5 to 6 types of rhinosporidiosis. One is rhino-orbitocerebral mucormycosis. Uh, Pardon me, I told rhinosporidiosis. It's mucormycosis. Now, the rhino-orbitocerebral mucormycosis, which is ROCM, it involves the symptoms like first nasal stuffiness, foul smell, epistaxis, nasal discharge. Then that patient will have unilateral facial edema, diplopia, proptosis, pain and redness around eyes, loss of vision, restriction of the eye movement, palatal and palpebral fistula, blackish discoloration over the bridge of nose or palate, and they will complain either unilateral or a frontal headache, loosening of the teeth, jaw involvement, and altered mental status. Cutaneous and soft tissue mucormycosis, they present with blackish scar at the trauma or puncture site, muscle pain with a deeper involvement, and there can be erythema and induration. Pulmonary mucormycosis patients, they present with a progressive dyspnea, non-productive cough, pleuritic chest pain, and the fever will still persist even after using a broad spectrum antibiotic. Gastrointestinal mucormycosis present with fever, bleeding per annus, mass-like lesions, and perforation of the gut. Mucormycosis of the bones and joints, there will be local pain and tenderness, and cellulitis fever is rare. Disseminated mucormycosis. Symptoms vary as per the site of involvement, mostly associated with pneumonia. Now, who are more prone for this mucormycosis, or whom should we suspect mucormycosis? Actually, at present, mostly the cases are case of concurrent or recently treated severe COVID-19 patients, and uncontrolled type 2 DM, chronic granulomatous disease which cause immunodeficiency like HIV or AIDS or prime immunodeficiency states. Then if you are using immunosuppression drugs, that is steroids, at any dose use more than 3 weeks, or higher dose of steroids is when it's used more than 1 week. Then use of tocilizumab or other immunomodulators. Then if there is prolonged neutropenia, trauma, burns, and IV drug abuses, prolonged ICU stay, post-transplant or malignancy, then voriconazole therapy, and renal failure, diarrhea, malnutrition, low birth weight infants, or even children or adults. Coming to the diagnosis, patient actually typically present with the symptom of headache, nasal stuffiness, or expectoration or discharge of blackish sputum. But how do you investigate this condition? Actually, for whatever the case, we will have that uh, routine panel which involves CBC, ESR, then sugar values, and HbA1c to know how the blood sugar is controlled in COVID patient, LFT, KFT, with electrolytes and viral markers. And directly you can see with a diagnostic nasal endoscopy if there is a crusting, debris, scabbing, granulation, or discolored mucosa. Either it can be pale mucosa or it can be a darkened mucosa, decreased bleeding, and insensate mucosa. Images we require for this is CECT, nose, and PNS. That is, there will be erosion and thinning of the bones, enlargement of the masticator muscles, mucosal thickening of the sinus, and change in the fat planes. Contrast enhanced MRI of brain, orbit, and face. You can see for optic neuritis, intracranial involvement, and to rule out there is cavernous sinus thrombosis or infratemporal fossa involvement. Microbiological test involves KOH mount and microscopy. Direct microscopy can be done by fluorescence. And what is the finding? The typical finding is a non-septate hyphae or ribbon-like hyphae, and there can be vessel occlusion. Histopathology, there can be hemorrhagic infection, coagulation, necrosis, and angioinvasions. Fungal culture, the media is cultured at a temperature of 30 and 37 degrees Celsius, and there will be cottony, white, or grayish black colonies. And about the sample collection and transportation, KOH should be done in saline. Fungal culture also should be collected in saline, but histopathology specimen should be in 10% formalin. And whatever the sample you have collected, it should reach the lab within 2 hours. And better not to send swabs if pus or sterile body fluid can be aspirated or when the tissue is obtained. Then the sample collection according to the site of mucormycosis. If it's if you are suspecting a rhino orbitocerebral mucormycosis, you can scrape or you can take the exudate from the nails, hard palate lesions, sinus material, or biopsy from the extracted socket area, and or endoscopic collection of the debrided tissue or biopsy. Then cutaneous aspirations collected with sterile needle and syringe from the undrained abscess can be used. And pulmonary from sputum and ball collected by bronchoscope, fluoroscope guide, transthoracic needle aspiration or open lung biopsy. If it's gastrointestinal, you need endoscopy of the lesion, and renal means biopsy of the lesion. Now, possible or proven ROCM, urgent surgical debridement and strict glycemic control is required. And the treatment is like injection amphotericin. This is given as dose of 1 to 1.5 milligram per kg per day. Or liposomal amphotericin 5 to 10 milligram per kg per day. Intracranial involvement is there. Or injection amphotericin B lipid complex 5 milligram per kg per day. This should be continued till the resolution of the initial indicative findings on the imaging. Second line which can be used or easily available is a drug called posaconazole. It's a broad spectrum azole available in both parenteral and oral formation. Dosage is 200 milligram 4 times per day. Alternatively, there is delayed release tablets which you can use as 300 milligram every 12 hours on first day, then 300 milligram once daily taken with food. Now, what are the things to be monitored? If you are using injection amphotericin B or injection amphotericin, liposomal amphotericin B, 14 to 21 days depending upon the severity, till clinical resolution we'll be using. After 14 days of therapy, shift to posaconazole if clinically the patient is stable. Now, pediatric conversion should be done